Colleagues, good evening. We'll give a couple of minutes for people to keep building momentum and joining the webinar. So just give me a minute and then we will start. Right, it's a minute past and colleagues continue to join, but as they do, we'll give a start. Can we take the slide down, please? Thank you. I wanted to start the webinar today by reading out a letter I received. It said, "Dear Dr. Mohit, I wanted to say that I have been listening to your webinars for some time. I find them very helpful and enlightening. I have been working in primary care for the last 6 years and have found the different perspectives shared by your many speakers so wonderful and enlightening. In my view, the variety of speakers and consequently the variety of topics picked up make the webinar so interesting. What I really like is the fact that the topics you pick up are so pertinent. Thank you for the time you commit personally to making the webinars happen. Thank you for posting the recordings on social media. So even when I or colleagues are unable to access it, we can hear the webinars at a later period. I'm going to stop because the letter goes on for a bit after this. But I did want to share how incredibly humbled I felt when someone took the time to write that to me. It just made my day, as each one of you do when you join this webinar and register for it. It's moments like these that make the effort in developing and conceptualizing this webinar so very worthwhile. Colleagues, good evening. Some of you know me, but those of you who don't, I'm Mohit Venkatram. I am a doctor by background. I am also the host for the Future of Primary Care webinars that we telecast on a monthly basis. When I developed and conceptualized this webinar, I genuinely could not imagine how successful and popular it'll be. On today's webinar, we have over 250 participants who have registered on multiple social media platforms. Many of you know I also work as the Deputy Chief Executive for Northeast London Foundation Trust. As an organization, we have always believed that if we worked really closely with our primary care colleagues and partners, together, we could make a phenomenal difference to the lives of many of the residents who want to access services that are provided. It's with this motivation alone that Northeast London Foundation Trust is supporting the webinar that was developed by me with an aim that we use our corporate resources with our GP and wider primary care partners, and together we enhance the outcome of our residents. And I think it's the reality of this, the honest truth of this, is that the success of this webinar is really in the value you all provide by actively participating. The numbers registered today are a testament to the support you all give and make this so successful. So an incredible thank you from me for making this a quality outcome for us all. Many of you who have been attending the previous webinar sessions also recognize that we always spend a bit of time spotlighting primary care activity in each of these webinars. The figures for July have just been published by the National Centre. And in all honesty, I was blown away by the level of activity done in 1 month. Many of you know we used to hover around 29 million appointments, and on occasions, primary care delivered 30.5 million appointments on a month. And I used to always say how phenomenally impressive it is to see those figures. In the month of July, hold your breath, primary care in UK delivered almost 34 million appointments across the country. It is such a seminal moment for the work done by colleagues, for the absolute hard work done by colleagues to make sure you and me are safe, you and me are cared for in a place away from the hospitals, so people who genuinely need the acute care can access it quicker. Of these appointments, nearly 44% of appointments were same-day appointments. So it's not like people got appointments a week later. Nearly 44%. So that's just tad under half the percentage. 90% of these appointments were attended by us. And I do remind colleagues over and over again, that means we lost 3.5 million appointments, roughly. Now, almost 45% of these appointments, a similar number to the ones delivered in the same day, were done by GPs. And one of the figures many people have often quoted is, yes, but the GPs just give me a phone call. Actually, of the 34 million appointments, 63% of these appointments were face-to-face appointments done by primary care colleagues. I have to say, when I read the figures in preparation for this webinar, I was awestruck. Hats off to a sector which has my greatest respect for delivering and working so hard to care for all of us in the community. Many of you would have heard the rumblings that have been going on in primary care for the last few months. There has always been this conversation if the traditional partnership model that has been the bedrock of primary care for the last many, many years is the only model of delivery. There have been speculations around what the other potential models can be. And is there a model that might give different benefits so that together with the partnership model, it provides wider opportunities. As one can imagine, it's a very, very emotive subject to have to talk about. And there are many national pilots that are currently trying to identify alternative approaches and learn from them so that we can develop the next evolution of primary care, recognizing the benefits and strengths the current partnership model brings. I'm incredibly pleased to share that our guest today is Dr. Rehaan Ansari, one such pioneer who has been piloting and learning from the rollout of what could potentially give us some understanding of the possibility of rolling a new model out. Now, many may ask, with Dr. Ansari's absolutely phenomenal background, which, if I may just for a moment pause, I don't think I would do full justice to him if I did just rattle off what all he has done. But to just name a few, in addition to being a GP, has been the director of the local federation. Is the clinical director of the primary care network. He has been the clinical lead for the mental health transformation. He has been the medical lead for physical health and eating disorders for children and young people. The phenomenal range of experiences he brings gives the insight that's required to truly understand how primary care can benefit best from the wide range of interactions it needs to have with so many other organizations. And I'm really grateful for the time he's giving us today. But just before I hand over to him, a quick reminder to colleagues. There are over 250 of us registered in multiple platforms right now listening to this webinar. So if you have a question, please go to your Zoom platform, click on the Q&A button, and post your questions there. Once Dr. Ansari's had a moment to share his views on the reflections and learning from trying to roll out a different model, it'll be great for us to use your questions as a conversation starter. Rehaan, it's an absolute pleasure to have you on this webinar, and thank you so much for your time today. May I hand over to you to share your views on the learning of what's coming out from your pilot?
Sure. Thank you, Mohit. That was a very kind introduction. My own introduction for myself is going to be slightly different if we can start the slideshow. Whilst we're getting started, my name is Rehaan. I am, I've certainly done all the things that Mohit has suggested, but I'm approaching, well, I've just finished my fourth appraisal, so I'm into my fifth year as a GP now. So there's been quite a short period of time where I've done quite a lot of these things, but I think it's just because I like to be busy, and my wife thinks it's because I don't like to spend enough time at home. So what I wanted to talk to you today about was really some of the amazing opportunities that we've been given in general practice about how we can develop moving forwards. We've certainly been placed at the centre of the NHS 10-year plan for the delivery of the neighbourhood model. However, in practice, this does come with some complications, and I wanted to share my reflections on some of the challenges that we faced as being part of the NHS England GP pilot. If we can just move on to the next slide, please. So this is me and my daughter. Inara has just turned 4. She just started at school. And another thing that's really important to know about me is that I'm an Arsenal fan. At the moment, quite long suffering, but I'm hopeful, eternally hopeful things will change.
Our commiserations, Rehaan.
I appreciate that. I'm a single-handed GP partner. working at practice in Lincoln. We're sort of eight and a bit thousand people, um, very urbanish for Lincoln anyway. Alongside that, I'm the PCN clinical director for IMP, and the Federation director for IMP Fed Healthcare, which is the sort of joining federation for the PCN. So I think I bring a good balance of um, uh, working as an autonomous practitioner in a practice where uh, basically everything revolves around me. I've created a practice in my own image, working in a trauma-informed model using a consultant GP MDT-led approach, and at the same time working on a much larger scale as the PCN clinical director, covering nearly 70,000 people. So I think that I get to see from both sides, and I do recognize that there is a balance when we are looking at the needs of the individual practices versus the needs of the whole system or population to try and achieve healthcare outcomes that are meaningful and long lasting for the future. Could we go on to the next slide, if that's okay? So I just wanted to give a bit of a background for IMP, our PCN. I've put on the screen a map that covers our area. It's roughly the same geographical size as Sheffield, but we have this small area at the bottom, which is very densely populated in Lincoln, and then we have a large rural area where population density drops quite significantly, but that does lead itself to much different challenges. We've got a good diversity in socioeconomic backgrounds. So we've got in some parts of the centre of Lincoln, we've got very wealthy people. We have those people right next to council estates, very deprived council estates. Some of actually the most deprived council estates in the country. And then in our rural areas, we have rural wealth and also quite a lot of rural deprivation. And because of that diversity, it means that we struggle sometimes as a network to find something that will work for all of us. If we can just go on to the next slide as well. So to give a brief background about the pilot, I'm sure many of you know about it already. The intention is for NHS England to understand what will happen should you give practices an additional 10% worth of funding. And to achieve that, they essentially brought forward what our projected 28-29 global sum funding is to 25-26. And using that additional funding, we have been given the opportunity to see what could happen, see if we can develop some new services or bring in some new ideas that will justify in the future NHS England materially adjusting the funding structure for general practice. And so I think it's quite important work. And certainly that was my motivation for joining. Across our network, we have various different motivations for becoming part of this pilot, and we'll come on to talk about that. But from a structure perspective, our PCN covers 9 different practices with 9 different priorities. And so consequently, we had to try and find a model that would best fit us both. We will have the population needs of the PCN versus the individual practice autonomy of each practice wanting to make sure that they are able to meet the individual needs of their patients. Because our budget for the pilot was roughly £1.5 million, which is relatively substantial money, although one of the things that I have come to learn in healthcare is that really doesn't go very far. We've given half of the funding to the PCN to do at scale projects, and I've put on the screen the aging well team, which we'll come on to discuss. And then half have been devolved back down to practices to facilitate them using their local intelligence to develop their own internal practice structures or change their staffing structures to best support their needs of their local community. We hoped that this model would facilitate us being able to build at scale, but still respect the local autonomy of our practices. And it was a complicated negotiation even to get to that part. But as a clinical directorate and as the leads of each practice, we felt that this was a good balance to strike. Now, one of the challenges, of course, we found was that about the different motivations that we have. And this is really where this started to come out. So I'll just give you a very quick preview in that we have, as I'm sure you will know, GP partners who are very financially motivated. You will know GP partners who are very innovative and forward thinking and are happy to take a financial hit if it means that we can push forward onto the next big thing. And so we have this diversity across our PCN, and trying to marry all of these thoughts together from people who have traditionally been very independent individual practices and clinicians has been a challenge. And I think it feels like one of the challenges that's not really been spoken about enough when it comes to thinking about primary care at scale. So firstly, what I will do is I'll talk about the things that have gone well. If we can just move on to the next slide, I'll tell you about the Aging Well team. Now, as part of the PCN, you will know that there is funding available and an expectation to develop what they call the Enhanced Health in Care Homes team. And as a PCN, we have quite a well-developed EHCH team. We have a physio, pharmacist, occupational therapist, and a GP who just look after our 500 care home patients. So we wanted to build on this and move into the community in a way that's not necessarily been done, certainly locally, through what we call the Aging Well team. The intention of the Aging Well team is to pull that EHCH expertise initially out to our housebound patients across the network, with a view to do comprehensive geriatric assessment, make sure that we're plugging people into all the right community services, using the virtual wards as best we can, in order to try and keep people as well as possible. Our anticipation is that this Aging Well team will grow further, and hopefully, or our intention is to capture people who are at risk of becoming frail, do the interventions there at that point, reduce or slow the onset of the frailty syndrome, and therefore reduce healthcare spend. But that's going to be a really difficult piece of work, because not only is it complicated to find those people who may not be necessarily approaching healthcare, but also it's going to be then difficult to track them 5 or 10 years into the future to demonstrate that the intervention that we're putting in place now is going to have meaningful benefit. But we're hopeful, and the vibes are good that this is the right thing to do, so we're pressing ahead with it. And the next thing I want to talk about is the things that we're doing at an individual practice level. So if we can just move on to the next slide, we've given practices their capitation-based funding split of that 50%. And we've had some really cool ideas from across the network. One of our practices has moved to a GP-led total triage model, which has cut their waiting times for a routine appointment from 6 weeks down to less than 2 weeks, which is really, really good news, because as our largest practice, they were struggling with the weight of complexity. Netlin tends towards older people, tends towards more complex people who require senior level input at the front, rather than having different types of professionals seeing, and actually making that change, putting their senior GPs right at the front, doing the triage, seeing the patients, has been really transformative for them. In another practice, which is in the more deprived area, we've had a counsellor starting who's been dealing with that sort of low-level mental health, trying to prevent the over-medicalisation of poor mental well-being and address problems in a slightly different way, which has had some fantastic feedback. I'm really excited about that as a project. I'm hoping that if we can get some good data to back it up, then we can roll that out across our network. And then there's my project, my baby, which is we have used population segmentation to identify those of our patients on our list who would benefit most from continuity. And we've done that through the population segmentation tool, Pathfinder. And from there, we have been running an NDT 3 days a week to just review all of them constantly. We've probably got about 350 people on that list now. They've all been reviewed twice since April already. And what we've demonstrated actually is the work that we're doing front loading now is reducing the chance of emergency admission, reducing the chance of prolonged hospital stays. It's reducing our new demand for appointments. I think it's working really well, but I am biased because it's my idea. If we can just move on to the next slide, I'll tell you about some of the challenges. So we had a simple idea. I thought that medication reauthorization and issuing happened in the same way in every practice. We all use System 1, medications all come in via the NHS app or they come in via System Online or whatever, come as a task, you just action the task, it's done. That was very naive of me. Our plan was we would have an external provider, a pharmacy provider, would just do the same thing for all of the practices, irrespective of capitation, irrespective of the number of medications that are required. It would just be a task that is taken away from us and done centrally. Now, what we found was that every practice has some variation on the way that they do medications. Some have admin teams who are leading on it with some clinical input when required. Some are clinician only, and then both of which are very unwilling to budge on those. We found that some are using tasks in a certain way, some are using tasks in a different way. So trying to unify all of those processes in order to be able to deliver a single service that would work for all of us proved to be an insurmountable challenge. And what it demonstrated was something that was actually quite powerful and quite frustrating about this whole situation, which is that practices have been working autonomously since the development of the NHS, if not even before. Some of our practices are very old, and they have been working through various different guises with various different partners, essentially in isolation for this whole time. We are not in a healthcare economy that has fostered the development of federations. The ICB has been supportive in principle of the federations, but there haven't been very many contracts coming out. There hasn't been very much chance for development of at-scale working. So we are 9 practices joined together by the PCN DES that just happened to be in a federation. Coming into the pilot it felt like a new chance for us, a new start. We were enthused at working together and doing something quite cool, even if we were going against the BMA advice. We felt that because of the size of our PCN, because of the population that we serve, we would be doing them justice by engaging with this as a service. That togetherness lasted for about 3 months. And then after that, some of those cracks started to appear, the reasons that we were not together in the first place. And this medications management service was a big catalyst for it. So what I had learned is that the sovereignty of the practice is almost sacrosanct. You have to, at least in our PCN, respect always the practice's ability to do their own work. And anything that we do as a PCN has to supplement rather than replace. And that was an important lesson, and I'm glad that we learned it at the start. Because the next thing that I wanted to talk about is a much more complex issue. So what we found, if we can move on to the next slide, was that when we had joined together as a PCN, estate for all of us was complicated. Many of us were working already at 90 to 100% capacity, but there was area differences in that. So our ICB, and I believe all ICBs, asked our PCN to come up with a unified estate strategy. And we had all of these high-minded goals of sharing space and developing clinical areas that are practice agnostic, and practices can just book rooms and come and work in them. But actually, when it came down to it, everyone said, what's my practice's share of this? How am I going to benefit? How is my practice going to feel the benefit of these new estates? And this comes from a history of differences in the way that practices have received funding, have been in either the right time or the right position to receive some estates funding from the from the previous CCGs or the other organisations that had been in place. And also, what we hadn't anticipated was a much deeper distrust of other practices because of historical inequities in the way that the Carr-Hill formula has been applied. So we have practices in the city which have got a high level of young frailty because of poor mental health and worklessness and loads of the musculoskeletal challenges that come with obesity. And they are generally not as well funded through the Carr-Hill formula as a practice with wealthier, older people who are working until older age, who are generally staying fit. There, we ended up with some quite large disparities in the way the practices were funded. So consequently, I'm sure you can imagine, those well-funded practices over decades will have better services, better staff, greater staff proportion are doctors. They have more consulting rooms per 1,000 patients than those practices that don't have that. And everyone said that they needed the same amount of space. So how could we as a network try to work out who needed more space and who needed space first? This proved to be a really complicated problem for us. We tried to be as fair as possible. We divided space out into per 1,000 patients, types of clinicians that are being seen. We looked at overall room utilization, and we thought we'd figured out something that was relatively fair. But no one thought it was fair because the person who was coming out at the top thought, okay, fine, this works out well for me because we know through our local intelligence with the ICB that they're going to be able to fund 1 or 2 of these projects. But when you get to 3 downwards, then it's going to be really difficult to get any scraps of funding from the ICB to be able to deliver any new things. So everyone wants to be number 1 and 2, but we can only have 2 people there. So what that led to was just a total paralysis. We couldn't do anything. And the ICB came in and did their own analysis of our estate requirement. They did a horrendous job of it. And so consequently, nothing happened. And really that was an opportunity lost because we know now that capital for a state is probably not that difficult to come by, but an ICB supporting an increase in rent long term is really difficult to come by. So those practices that have been able to get in early and change their estate footprint or add in new rooms or new buildings, they've been lucky. Now no one else gets anything, and we are all as a network in that no one else gets anything, which is further highlighted some of these challenges, these deep-rooted challenges about what it means to work together. If we could just move on to the next slide. These are the 3 areas that I found. I've been in post now for just over a year, so this is something that I have been thinking about even before this role and then certainly throughout this role. Number 1 challenge that we face is that there is a difference in culture between the PCN, which is a large-scale population-level organization that has to address things in potentially a practice-agnostic way by focusing on communities, on population, and delivering healthcare to those populations. And at the same time, we have those individual practices with their long histories and their deep ties to their communities and patients. Who is in a better position to deliver large-scale healthcare? I would argue that the practices are able to do it, and if we as a PCN can support that, that is probably the best way of being able to deliver meaningful change. However, it feels like the way that the direction of travel is being given to us, certainly from within the 10-year plan and from NHS England, is that we just lump together and we deliver primary care at scale, but it may work in some areas, but it may not work here for us. On top of that, we have this problem of legacy. In our network, we have two practices that operate out of the same building, who used to be the same practice, but then maybe 30 or 40 years ago, they all fell out. So now we have two separate practices serving the same population. And that is a historical inequity that no one has really been able to shake. You know, the staff have changed, the partners have changed, but it's there. And we have that pocketed around the PCN. That's exacerbated by these changes in funding that we've had. We've had some practices that have been parts of pilots and been able to receive additional pots of funding that way. We've had some practices that have had new estate built for them, and it's difficult to work in a new future where we have to say, okay, look, we have to draw a line under all of this, or under these decades of mistrust, and let's just do something different in the future. It works for a little bit, but actually it always in unexpected ways comes around to rear its head in a way that we're not expecting. And then finally, and I think this is probably the most important thing, we've noticed that there is a significant difference in motivation for doing things. I would consider myself in the former camp. I'm 35 now, or 34. I've been a GP for 4 years. I've only known the NHS to be dreadful, to put it mildly. It's been a difficult slog. You know, I grew up my first year as an F1 was when we had our first round of junior doctor strikes. Since then, we've had challenges with funding, cuts to funding, and no real progress has been made, or it feels like no real progress has been made. So that's all I know. And yet, some of my colleagues in the different practices have been GPs since the early 2000s, when I am told it was a good time to be a GP. The patient list size wasn't that complex, the relative funding was pretty good, the autonomy and the respect that you got as a professional was very good. So we have these differences in how we view the younger GPs, perhaps potentially a bit more innovative, potentially a bit more forward community thinking and less practice focused, and those of our partners that have been established for years, decades, have a more protectionist view over their patients, both of which are sensible and valid approaches to being a GP, being a partner, and working in a system like we do. But sometimes without the right motivation and guidance joining you together, then you can find yourself at odds with your colleagues, which leads to decision paralysis and actually leads to many missed opportunities. So just before I end, I wanted to leave with some takeaways. If we could just move on to the next slide. I think that a hybrid model can work really, really well. Having that PCN as the gel that binds those individual practices together, but does not take away from that practice autonomy, it has the potential to deliver long-term meaningful change for general practice. But in order to do that, you need to have within each practice innovators who are willing to push forwards, look upwards and outwards, and join with their fellow practices to be able to make something or work in some way that's slightly bigger than just the practice. In that way, we have the PCN giving and we have the practices giving, rather than either the PCN or practices just taking away. If we can get to that model, I think that any PCN, any set of practices can really push forwards and make the best of the new 10-year plan and the way that healthcare and general practice will be changing over the next decade. I found that the biggest barriers are not operational. Operational problems can be resolved relatively easily, Actually, if you get the right people in the room with the right motivation, you can solve anything. But what you cannot solve really quickly is culture. You cannot solve history, and you cannot build trust easily. When thinking about how to um, move forwards as a network for ourselves and also the learning that I want to share with us all today, what I really wanted to highlight was how the first thing that you have to start with is building trust. Get to know your fellow clinicians, get to know how they think, what their motivations are, and then how you can work together. Figure out how you can work together. And from there, you can build and do whatever you want. Now, I am confident and I'm certain that there are future leaders amongst us um, in this webinar or working alongside us that will have the skills, that will have the motivation to be able to work and make those changes. I'm the youngest person in our PCN meetings and the youngest person in our ICB meetings. I'm usually the youngest person wherever I go. And I don't mind that. Like it's like a selling point for me. But I've been afforded these opportunities to be able to come in and make some meaningful changes in a role or in a place that I intend to be for the next 40 years of my life. I'm only at the start of my career, and actually, probably by the time I come to the end of my career, the retirement age will be somewhere around 100. So I'm anticipating making these changes for myself in a decade, 2 decades time. And so I know if I do the work now, then actually I can make my life a bit easier. I know that there are going to be colleagues of mine who feel the same way and I try to give them as many opportunities as I've had. But what I would like from you all, if you can, is to try and identify some of those people from your colleagues, either in general practice, in other parts of primary care, or in our secondary care acute settings, and build them up, lift them up, help them to develop into those leaders for the future who can not only navigate things clinically, but also work to build these bridges together so we can start moving forwards into a better future for both general practice and healthcare in the NHS in general. Thank you very much. Oh, there is another slide, but this is just me and my daughter at Bewilderwood. I don't know if you guys have been to Bewilderwood in Norfolk. I went there over summer. It was really fun. And as you can see, I am very good at making myself a little crocodile hat. I think we've been collecting some questions, and I'll pass back over to Mohit to take on the next part of this talk.
Thank you, Rehan. Thank you so much. That was phenomenal. And how time flies when you're enjoying yourself, because I have lost track of time and suddenly I realized we're well over what we had agreed to because it was just captivating. And it was from the heart. But first things first, the most important thing to share with you, you have an incredibly beautiful daughter and very sweet looking. Give her our best from all 250 of us here today
I
and many
will.
more wider people. I think it is phenomenal. I mean, there's some comments already about how very authentic people found that, and they wanted to thank you for being so honest and transparent and authentic in this process because it is very hard when you're trying something new. It's never been done. 70 years of NHS history, we are trying to turn away 70 years of practice and ask you to do something. And I don't think you came across as a young man. All you came across was someone with considerable experience and insight into the work you've been doing. So I'm going to ask you the first question, which is what motivated the PCN to sign up to this initiative? Because the reality of this is it's wrong to say it's a poison chalice, but it was challenging the bedrock of what GPs have believed to be the sanctity and security of their working haven of being practice partners. So, how did you come around to saying, let's sign up to this initiative and try something different?
With quite some difficulty, actually. As I'm sure you can imagine, trying to convince 9 separate practices to do anything was very complicated. My colleague David Sheehan, who is my co-clinical director, and I, um, we felt that it was probably the right thing to do. And certainly my own motivation was that actually I want to be leading change. And I felt really strongly that the changes that we could make and demonstrate as part of this pilot could have wide reaching consequences for the next iteration of the GP contract. And if we can do it properly, then we can show both ourselves and our neighbouring practices and practices around the country that we don't have to be so focused on some of the larger urban areas when we're thinking about GP contracts in the future. This is how we do it in Lincoln, and this is how we can make it work. And I think probably about a third of the people that I needed to convince thought the same. The other third, maybe a bit more financially motivated. Actually, do you know what? There's £1.5 million extra coming into the PCN. This sounds pretty good for me. Maybe I can make this work to my benefit. Also valid standpoint. And the other third, I think, probably just went along for the ride. And that was okay. I didn't mind that because those people who are just there, they're happy to go along with what the majority think, and they're comfortable with whichever direction the PCN goes. Really helpful because if we can demonstrate that what we're doing is working and that our motivations are good for doing it, then most people are pretty easy enough to convince from that perspective.
Uh, really insightful. I think it just leads on to the question around having done this work now, do you really think contracts, a change in the contract is what's going to be required to making change happen? Or do you think there are other levers one should focus on?
I mean, it's a really good question, and thank you for asking it, Sally. The A contractual change is an easy mechanism to sort of force change on a large group of people, and that's, I mean, so far throughout the GP contracts, there has been a way of leveraging large scale change. In some senses, you can force through a lot by making a contractual change. We'll look at the upcoming uh, extension of online consultation tool hours to core hours. Now, that's a really big change that's been forced through by a contractual mechanism. So there's precedent for being able to do that, but actually, a lot of nuance is lost in being able to do it. A lot of the local practices and ICBs, PCNs working together to make a system or a service that works for the local population is lost by using quite a blunt instrument as a contractual change. So whilst I do think it is important to make some changes through a contractual mechanism, I don't always think that is the best way to approach. If you go from the ground up and you make the changes first, and then you make the contractual changes to support those changes that have already been made, it feels like it'll be a much smoother process than having no change, force the contractual change, and then everyone is then scrambling to make the changes that are required or that are centrally required from there.
So Rehan, I mean, clearly the fundamental question that comes in from your learning, and as I distill this into what is the crux of the issue, is how do you develop a common value set in a group of independent practitioners? And given we as a nation have promoted the independence of primary care, let's be honest, that was not what the GPs did. That's what they were asked to do. How would you suggest given your learning and extensive learning and work on it and such insightful slides, how do you think can that be tackled?
I wonder whether the way that primary care is taught, both to students and to our resident doctors, will need to change, because there's no, you know, I'm a nepo baby. My dad was a GP, and so I understood his GP partner. I understood general practice and partnership and what that means before I became a doctor. But I don't think that a lot of people do. And what that leaves is people to learn about primary care partnership through the partnerships that they're currently in, and um, that sort of entrenches culture within of that practice within anyone new who joins. But actually, if you join with a different understanding of what general practice is, and a different understanding of what general practice can be, then you can start to bring change from within. And once you have brought change from within each practice, to not necessarily being so focused down on their own population, but up towards how can we engage with our neighbors, how can we engage with the PCN, then we will start to see more cohesion, better change within the network itself. Uh, Part of that would be the development of a shared mission statement, a shared values, which we've done. And actually, we can always then now go back to our shared values, our mission statement, to say, this is what we have agreed to do. And then once you have that, that you've all agreed to, you've all signed up to, you have a much more clearer understanding of what is expected of you and what is expected of the network. So you can work better together to have better outcomes for people.
Thank you, Rehan. And I agree with you. I think if we tackle this at the root of the training itself, so that the group of people who come in as the next generation come with a different perspective, you're able to tackle what was pretty incestuous in the culture, not incestuous in practice, but in the culture of how primary care has been set up in the first instance. And I think colleagues would notice that what we are challenging here is the independence of practitioners and the autonomy with which they have practiced to create a very different model of more dependence, more interaction, more accountability. And that is a different model. That is fundamentally different to how they practice, fundamentally different to what the model and structure is, and does require a very different approach altogether. I think the question, though, that leads, and you shared some, I would say, early findings, because my view is if you're going to make change, it takes 5 to 7 years before true change happens. So if this pilot doesn't continue over the lifespan of what you said was 2029 contract payments, which were brought forward in 2024, so that you can use the resources in a different way, the global sum uplift in a different way. The question I have, though, is how do you truly measure the success of this pilot? Because the current measures or the current findings are still transactional. How would you suggest? Because what I didn't get to hear in your conversations, no, let me start with what I did get to hear. What I did get to hear was the approach to population health in some of the projects. What I didn't get to hear was the involvement of research or the involvement of public health to do that longitudinal study to truly be able to talk about the benefits of this additional investment. How would you suggest is this measure done to say Is this a successful venture or is this nothing more than lip gloss?
I suppose there's two ways of thinking about this as an answer, and it's a really very interesting and nuanced question. As the pilot itself will be collecting data longitudinally over the length of the time that the pilot is collecting data for, um, to see how things change. And actually, we are doing every couple of months uh, quite comprehensive audits to understand how the balance of work is changing throughout the lifespan of the pilot. We have one coming up next week, actually, which no one is looking forward to because it's um, such an intensive piece of work. Everything that we do has to be logged. Every minute has to be accounted for, so we can judge whether or not the things that we are doing are changing the way that work is coming in, and then changing the way that the population is being looked after. Internally, because of the way that Pathfinder collects data, Pathfinder, again, as mentioned earlier, is our population health management tool. We can do longitudinal evaluations over 1 to 5 years to see what was happening before with a cohort or what's happening with a cohort compared to a matched cohort elsewhere in the city. So we have that availability and that power to be able to do those studies. But more importantly, if you are doing something right, it feels good. It feels good to work. It feels comfortable to work. You don't feel as stressed. You feel that you're looking after your patients better, and you feel that you're delivering care in the best way that it can be delivered. And I would argue actually that if you feel that the job that you're doing is right and you feel good at the end of the day because you know you've done a good job and you know that your patients are being looked after, that is just as powerful as the evidence that we will collect in a few years' time, because we know as clinicians we have our gestalt, we have our gut feeling, and we can often rely on that gut feeling to be correct, even if it seems weird. If we think that something weird is going on, something weird is probably going on, and if we think that something good is happening, that something good is probably happening. So that's how I am approaching it. I feel good about the work that I'm doing, and I go home every night and I think, actually, do you know what? MDT's done a fantastic job today. And that's been now shown in our few months worth of data that we've collected. But I'm hoping and I'm anticipating that in 3 years' time, when we can do our final evaluation of this, I can turn around and say, actually, do you know what? My feeling was correct. And I think if we can do that both, if you feel good at the end of your day and you can get that data to show that you're doing a good job, then there's really nothing that can you can argue against to say this is the way that you should be practicing.
Very, very fascinating, Rehan. And believe me, I mean, there's a colleague of mine, Jamo, who also commented on the fact that they feel they endorse your view of what's really needed to make a change. So it's brilliant to see that. And I mean, I can go on and on, but I know we have just a minute left, so I'll start wrapping this up. Uh, it takes a lot of skill, Rehan, in my view, to navigate through an issue that is so sensitive and so deep-seated in what people do. But the honesty with which you have approached it was really refreshing, really, really refreshing and brilliant. And the clear determination you showed to make a difference does make you stand out like a true GP. I've always felt GPs are a brilliant group of clinicians, and it just inspired me in so many ways. The process you followed in your PCN of using a tool of the contract, not for the purpose of contract setting, but for the purpose of improving the lives. When you spoke about people should smile when they do their job, is absolutely heart-rending. That's what we are here for. If we can improve the lives of people who are working, we can improve the outcome for our patients on a daily basis. I mean, it was just brilliant. And some of the things you said about understanding variability, when you spoke about the medication recording, people are starting from different places. So this view that we will implement one size fits all is never right. Something around Trust, 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 because historical inequity takes time to go away. It's not something that'll just roll off in a year or two. And then recognizing that you need time to truly create an enabling service where there's no power struggle, where there's actual agency to want to make the difference because people come from the same value base. I think you brought home the truth that change is never about the process, it's about the people and the relationships. And Rehan, you were outstanding. Hats off to what you did. Thank you so much for your time today.
Thank
It
you.
has been just brilliant. And thanks to you and your PCN for the time that you have all given today to share with us this contract model, an approach to it, and learning from it. It's absolute brilliant. I also wanted to take a moment to thank a couple of colleagues who sit in the background, Candice and Fran, without whom this wouldn't happen. So thank you very much, Candice and Fran. You're amazing. Colleagues, Candice will also put up a slide now with the QR code for feedback because it is your feedback that makes all the difference. I am so grateful to all of you for your active participation, for the encouraging comments from so many of you thanking us for the work that's being done in trying to pick up pertinent subjects that are of interest to us all. Please use the QR code to feedback to us what else we can do to make it better. And if you found it good, please say so. It was brilliant seeing you all today, and I hope you have a wonderful evening. Take care, everyone. Good night.
Thank you.